So I now like to introduce Mr. Richard Fan, who's the CEO. Well, Richard is now the chair of the board. He has been for a while of the Royal Caribbean Cruise Line, and he's a recently former CEO, who I assume is now spending most of his time golfing. Richard, good to see you again.
Well, thank you very much. It's nice to see you. Thank you for giving me this chance. I have now been, I gave up my title of CEO 2 weeks ago, so I am enjoying life. After 33 years in the job, I figured that was kind of enough. And the last 2 years was definitely kind of enough. I do have a short presentation. I have 8 slides. If I can put those up on the screen.
Yes, absolutely. We'll set it up so you can share your slides.
Does that show?
It does.
Okay. As you can see, this is not a detailed presentation. I will start with a comment that we in the cruise industry have a very long history with the CDC and with the quarantine division. Some 25 years ago, when I was still relatively new as CEO, we actually went to Washington to lobby for more work from the CDC and for increasing the budget in the maritime division, looking at us. And so it's a very long history. It's been a very successful one for most of that time and an important one to us. And it was very much focused on food safety, on more, and then more recently norovirus, but a fairly limited area, but an important area for us. My understanding here is that you're focusing very much on the quarantine division, and my comments were on that because those are the people with whom we've worked. And I really have to emphasize, number one, how important it is that that relationship work and that they do their job well, that they are in a very difficult position. I think everybody on this call understands how impossible the demands are on the CDC. And I would start out by emphasizing that we are, there is no doubt in our mind about the skill levels of those people or their commitment. I think the issue that I've been asked to address is what could we do to improve things going forward? And I think there's always room in any organization for improvement. Our mantra at Royal Caribbean Group has always been continuous improvement. We don't have to criticize the past to say we want to do better. And so that's the way we've taken that. In my comments here, they will come across as negative because the things that work well, I'm not going to talk about. But I do think this is an absolutely critical area. I know it's critical for our industry, and we are an important industry, generating hundreds of thousands of American jobs, as well as helping a lot of people in a traumatic time. And so I do think that there have been issues with the structure that my understanding was that may be helpful to you. And overall, I really have 2 subjects that this comes down to. One is communication and the other is structure. I thought I would start by commenting on other countries because we, of course, deal with lots of jurisdictions around the world, more than 100. And it is clear almost everybody took a slightly different position. There was not the kind of coordination you might have hoped to have seen internationally, but we did deal with more than 100 jurisdictions around the world. While I will point out that in our view, all of them were in turmoil, all of them were trying to find a solution. I would also point out that the US is unique on many grounds. And because of our size and the diversity of our country, we had issues that others didn't have. But we also, as a country, seem to be the least open to new ways of dealing with this. And we found in country after country that there was an interest in finding solutions as opposed to imposing solutions. And if you did a list of all the countries, at one extreme would be those countries that really through much of the pandemic were reluctant to have any kind of a dialogue with the industry, whose communication wasn't what you would hope it to be. And the US would be at the far end of that extreme. Actually, it seemed like the US was less confident than other countries in its willingness to discuss, to look at other areas. And we were dealing, for example, I'll just pick two countries. Singapore was one of the most cautious countries in the world when it dealt with this. They were successful in a zero COVID policy. They did it by essentially closing their borders. And when we started talking to them, they said, oh, the cruise industry, we've had these bad examples, these terrible examples. This is the poster child of what we don't want to do. But we sat down with them and we talked to them and we exchanged information. And the result was they came and said, oh, no, this is actually, there are ways to do this. And then when we did actually start operating out of Singapore, when the circumstances changed, either on the ships or on land, we adjusted, they adjusted. It was an amazingly close cooperation. And it wasn't just Asia. We had similar kinds of dialogues in countries like Germany and Italy, where still a lot of confusion, a lot of different, everybody had their finger in the pie. So a little bit like the United States, it wasn't that their health service, in our case, the CDC, had total control. It was they had a lot of people who all felt they had a right to weigh in, but we found a way to make that function, and it functioned very well in those other countries. And I think the US could learn from some of that. One of the biggest issues from our perspective was consistency. We believe that consistency is critical to an organization's credibility and to the respect that it engenders. And we felt that consistency was lacking here in the US and in dealing with some of the issues. And some of it's understandable, but some's not. So, for example, the working with the airlines, there was a rule that everybody had to be tested using antigen testing, at least antigen testing. That was fine. No specificity as to which one, and as we all know, there's a high degree of variability among different kinds of rapid tests. The cruise lines under the CDC rules were supposed to be using PCR tests. PCRs are amazingly effective and accurate compared to, particularly on sensitivity compared to the rapid tests. We went out and at great expense and great difficulty found Cepheid is one of the leading manufacturers, well-respected manufacturers. The CDC had approved a Cepheid machine for one of our competitors. We went out and bought them across our fleet, and then we're told we had the wrong model of Cepheid machines. We did spend 3 weeks with back and forth over that, and at the end of that period, the model that we had bought was approved. This sounds a little petty, but my point is that there seemed to be, on the one hand, well, any kind of rapid test. On the other hand, oh, you're doing PCR, but is it the right model? And it just didn't seem, it was a level of perfection that wasn't looked for in other areas over which the CDC exercised jurisdiction. And obviously, this has a relationship even with the within the CDC. I'm going to talk in a minute about the structure, but it did seem like there were different divisions, and it was more a question of which division was looking at things, and there wasn't a consistency across the CDC. Another example I would give, because I think it's relevant, was the normally in the US, any federal organization that exercises regulatory authority has certain constraints on their authority. They are actually required to do consultations, et cetera. In this case, the CDC argued that there were exigent circumstances so that wasn't incumbent upon them. But they didn't see that those exigent circumstances also allowed them to actually talk with people like us for quite a while. I'll come back to that structurally in a minute. I just want to make a distinction. If there's one issue that we had, it was communication. And I kind of like this. Communications do not equal communication. We had unbelievable amount of back and forth, loss of emails. But the example over the Cepheid machine is a good one. There was a lot of communications, many emails, many phone calls over that 3-week period, but no communication, no dialogue, no discussion. It was a little like playing tennis against a backboard instead of against a opposing player. So you didn't learn in that process. We actually felt, and other countries felt, that the cruise lines had an opportunity, both because we controlled our environment in a way that others can't do, but also because we can do things differently on one ship versus another. So we could have been, and in fact we were amongst ourselves, a laboratory. Try this out. What does this do? What does that do? What have we learned from that? We did a lot of that in Singapore, a great deal of that in Germany. One of our competitors did a lot of that in Italy. Let's try this, see what happens, see what the numbers show. We did some of that, but there was really no interest from in doing that. And also we were willing to do it on an industry-wide basis, so there was no interest in that. I'm trying to be quick. I know and I know I'm also at the end of a long day. I think one of the issues that we had was there wasn't any clarity on what was the objective. So if we said, well, what if we do this? The answer was, well, that doesn't absolutely prevent the transmission of COVID-19. It is still possible for it to go through. We never understood, there was never an articulation, there was never a discussion of what is the objective. We ended up adopting an objective amongst ourselves and saying, we want you to be safer on board a cruise ship than you are walking down Main Street. Now you can look at relative risks. Now you can have a discussion about relative risks. But when the only conversation is, well, if you do that, it is possible that somebody could get sick, there's really nothing to talk about because there is essentially no human endeavor where that isn't true. And so we think that the failure, I would argue, is a failure to identify an objective from the beginning, or certainly once we were into the pandemic, made communication very difficult, not only between the CDC and people like the cruise lines, but also within the CDC. And it was very clear from some of the extremes of what the CDC proposed in certain cases that people within lower levels didn't understand what the objective was, and if they have no guidance, they make up their own decisions. Now, maybe there was something going on there that we weren't aware of, but we tried to put together an objective. And during the pandemic, we put together a panel, which we call the Healthy Sail Panel. It was made up of experts in various fields, epidemiologists. We had an ex-CDC head. We had Stephen Ofra. Stephen was obviously a big person in the panel. And one of the very first things they did was said, what are we trying to accomplish? We think this also led to mission creep, because the implicit objective was no transmission. Since that objective was never possible, it just kept getting more and more, not is our objective right, but what more can we do to achieve this impossible objective? Show me the data. I like the movie, Show Me the Money, so I'm using the expression, but the data is what we were desperate to have. We submit daily information, tons of examples to the CDC, and essentially never got anything back. And that was extraordinarily unhelpful to us. For example, within the Royal Caribbean group, we were getting reports from our data analytics team that said, where you're having cases on board, it's from the J&J vaccine. Where you're getting cases, it's here, it's there. If you do this. So there's a lot of information that was actually helpful to us. And one of the pieces of information the CDC showed was, I forget what the exact number was, but over a period of 4 months from the start of cruising, there were a total of 1,400 cases on cruise ships. But they didn't distinguish between cruise ships that were operating and cruise ships that weren't operating, cruise ships that were vaccinated and ships that weren't vaccinated. And the Royal Caribbean group, we looked at that and say, well, proportionately, we should have, our numbers would say we're at the low end of that. But is there something we're doing that's better than the others, or is there something anomalous in the numbers that we're not aware of? So an opportunity to learn and share best practices, I think. But we wanted to understand the data so that we could learn together. And again, this comes back to the communication. I think it is a question of structure. It's not a question of these being not having people of a very high skill level or very high desire to do the right thing. It is a question of structure. In our own organization, when the pandemic first hit, our public health department felt that, well, we're public health and we should be handling that. These issues are total issues for the entire organization. And the CDC, I believe, had a structure where the quarantine division handled these kinds of issues. And the same organization that was handling them previously now took on this new regulatory role. And I think one of the issues which I would hope the CDC would consider is, do they really want to be a regulatory body? Because they're not set up to be a regulatory body. And you also can't have a small section, which is a regulatory body, while other sections are doing other things, because that does lead and did lead to the kind of inconsistency that we saw. A regulatory body has certain levels of experience and knowledge and ways of doing things that I don't think that the CDC has historically had. The CDC could clearly develop that expertise. These are a bunch of brilliant people who could do almost anything, but it would transform what the organization is and what it stands for. And we really saw that. What happened that really opened up the world to us, and in particular allowed us to start operating, was we had been operating overseas. We had been operating in a whole series of countries and working with their public health departments, establishing protocols, and it was successful. And we weren't getting there with the US. And then the CDC and others decided to put together a working group, which consisted of a new leader in the group from the CDC, but it also included representatives of other government agencies that had been more active in regulatory environments in the past. And they basically cut through the logjam. And the result was a dialogue that continues very effectively to this day, where we learn from each other. And I think it's because you now brought to the table organizations that were normally involved with a regulatory function in a way that the CDC hadn't. So I'm trying to be short on this, and I'll end with my last slide, which is we do need to respect the unbelievable challenge that the CDC faced. We do need to respect the effort and the focus that was put into dealing with this. And while inherently in a discussion like this, we talk about things that can improve, we do need to respect the things that the effort that everybody put in and the trial that they are going forward. So I tried to make that quick, and I'll stop sharing. And if there are questions, it would be a pleasure to ask. I should also say a thank you to you all for undertaking this task, because this is really an important task. COVID-19 is still here, and it and other diseases will be there in the future, and we need, as a nation, to be better prepared. Thank you.
Richard, thank you very much. Questions? Stephen, your hand's up, but it was up before. I don't know if that's from the last group. Jason.
Sorry, it was from the last group.
Okay, thank you. Jason.
Thank you very much, Richard, for your perspectives. Really appreciate it. I've taken quite a few cruises, and I think you're right that there are real opportunities in experimenting with different strategies. Can you tell us a little bit about what has been done from your evaluation team in terms of, for example, if a staff in a cruise would get infected, what are some of the options? If a passenger were to bring in new viruses when they go on a day trip and come back in, and what are some of the strategies? And then, because you have these like 2 or 3 week cycles where the passengers will change, and then the staff, I assume, stay longer each time they're on board, but then they could also get infected. And what type of modeling has been happening, and what type of testing and quarantine strategies have you currently put in place that you believe will work?
So early on, we acknowledged that while we could establish protocols that were designed to prevent COVID-19 from entering the ship, that could never be perfect. And so we had, from the beginning, three criteria, basically. One is perimeter protection, try and keep it off the ship. Secondly, if it gets on the ship, keep it from spreading. And third, if it's on the ship, how do you keep it from becoming an outbreak? And that actually worked extremely well. The testing requirements before the cruise and the requirement for vaccination before the cruise kept most of it off. But we always had, I don't mean always, but we often, by the way, I should thank you for your cruising history. That's very important. And maybe for the rest of you, if I could sell a cruise if I can't do anything else. Because we desperately need the revenue. So the first thing was keeping it off. Some will get through. Under Delta, it was very small. We rarely had a case on board a ship where we had more than 2 or 3 people who were infected. And because pretty much everybody was vaccinated, I would say that in a high percentage of the cases, the roommate did not have the tested negative as well. So the vaccination, of course, particularly before Omicron, was very effective. The second question is preventing it from spreading. There, I think we took the view, yes, some of our cruises, people wore masks, but by and large, the idea was just to keep it low enough so that unless there was reason to be concerned, that there just wouldn't be the spread because the vaccine would act as a prevention and therefore keep any spread to a very minor level. And then the question was, once somebody became infected, what do we do? With the crew, we were testing once a week. We've now gone to twice a week, but because of Omicron, but it was to get it early. The key was getting it early. If somebody was testing positive, we isolated them in a negative pressure area. We had a series of spaces that were negative pressure, and we put them in that. We then also went to their close contacts and we isolated or quarantined the close contacts. So before Omicron, very, very little transmission on board. And it was a delight, I have to say. Omicron changed all that because Omicron is so infectious. But even there, and so with Omicron, we went, oh, by the way, the crew all wore masks all the time. Guests, it was masks optional. Unless there was a lower level of vaccination, in which case they wore masks all the time, even before Omicron. With Omicron, we're wearing masks all the time. We are reducing our load factors to lower levels. So we're running today about 50% occupancy. That makes social distancing easier, et cetera. So that's essentially what we did. And that's worked out very well. Then we take the infected person off and isolate them in local hotels, or now, because the numbers have gotten big enough, we've taken a couple of ships and isolate them on those ships.
Thank you. Stephen.
Yeah, Richard, thanks for the presentation. So at the beginning, there was a no sale order. The no sale order was replaced by a conditional sale order from CDC, and as of last week, they're now voluntary standards. And I'm wondering if you can speak to how the perspective of industry, or at least of Royal Caribbean, in terms of your use of those standards now that they are no longer a requirement, and your view of one way of doing it versus the other.
So the no sale order was sort of a knee-jerk reaction that we don't understand this as well as we should, or as well as we'd like. So let's close it down while we sort this out. I'm putting words in the mouth, but it basically said we don't sail. The conditional sale order initially said you can sail under these conditions, and then the conditions became, and those conditions essentially amounted to a no sale order. Then it was made more feasible, I would say. And so we did start operating. We are now, as you say, it's just transitioned, just I think last week, they are now recommendations. But we were already operating well in excess of the order. So I think the order requires testing of crew once a month. We were testing every week. We're now testing twice a week. And by the way, this is not just Royal Caribbean, although I don't want to remind you, though, the other, you don't need to worry about the other cruise lines. Just need to remember Royal Caribbean is the best food and the best entertainment. And but we don't compete on the basis of the protocols. And so I think what I'm saying is pretty much across the board. And by the way, I am the past chair of our industry trade group. I'm still a very active member of the executive committee. So we're basically all following the conditional sale order, whether it's a requirement or not. And in fact, we are operating in excess of that because, you know, the real cost of this is not the 2 years we've gone with almost no revenue. The real cost is what it's going to do on a long-term revenue basis. And this is hurting us badly. And we all recognize that. So we need to regain the trust of people, and the best way to do that is to continue to show great results. And we did achieve as a result of that, and I think still are achieving as a result of that, you are a situation where you are safer on. There was a headline in the U.S. News and World Report, USA Today, which said, you know, cruising, it quoted somebody, cruising is safer than shopping at Walmart's. And that was the objective that we were looking for, that you were safer there than living your life on land. And we're determined to continue to do that. And so today, when the order went from a conditional sale order to a set of recommendations, it didn't change anything.
Richard,
And by the way, that's the way it should be. Sorry.
let me thank you very, very much for being here with us. I think we're going to need to move on, but happy sailing, and good to see you again.
Thank you. Nice to see you too. Thank you for inviting me. And what you're doing is important. Our country needs a better and more effective way of doing this. We all have to be learning during this difficult time. And I thank you for your contribution to it.
Thank you all.
Thank you. I'll get off.
We now want to hear from Mr. Donald Brown. He's the Senior Vice President of the Maritime Policy at the Cruise Lines International Association, so we can get his perspective. Mr. Brown.
Good afternoon, Chairman. Thanks to the committee for having me on to provide a view from the Industry Trade Association. CLIA represents 90% or more of global cruise line capacity. So obviously a worldwide footprint. Our members include Royal Caribbean Group, as Mr. Fain just was speaking to you, also Norwegian Cruise Lines, who you'll hear from next, from Mr. Del Rio, and many, many others. I would like to take the time today to talk to you specifically about some of the cruise line perspective with regard to quarantine stations, but then also to provide industry level update on our restart in relationship with the CDC. So if that sounds good, I'll get started. Kind of on the very specific side with quarantine stations, I have the benefit of working with chief medical officers and public health professionals from our member lines who are very close to the relationship with quarantine stations, as ships call, especially here in the US, in ports like Miami, Seattle, Los Angeles. And their experience with quarantine stations is limited in a sense and occasional because reporting of things like acute gastrointestinal illness and the various threshold levels of cases on board, or reporting of COVID cases under the enhanced data collection system with the CDC, actually are going directly into kind of portal-based management systems directly with the maritime unit. Whereas the more individual cases, like if there was a case of tuberculosis or meningitis on board, that would be handled through the traditional quarantine station reporting on an individual case basis of the illness and death reporting form. So on kind of that limited experience, the cruise lines have found that the system is a bit clunky and kind of labor intensive. And we say that because the form that needs to be used in order to make those reports, it's an Acrobat PDF, 4 pages long, reflects a form that's generally filled out for the most of the maritime industry by a non-medical professional, whereas on cruise lines, we have medical centers and doctors on board that are actually filling out the form and able to provide, you know, a clinical assessment. So that process of filling out the form is actually a bit antiquated. So on the recommendation side, we would think that that could be updated, it could be fixed, it could be portal-based and electronic to allow probably more timely reporting, a bit more comprehensive or insightful reporting from somebody who's more qualified than the typical maybe captain on a cargo ship that is not medically trained and submitting the information. And then on the receipt of that form side, the experience has been that it can often take in excess of a day just to get the review by the responsible EIS officer, to gain access to the on-call medical professional who's sometimes not even co-located with the quarantine station itself. So we think that online access, simplification of the data, the ability for the medical professionals on board to swiftly speak with somebody about the individual case that's being submitted via the illness and death form would be recommendations to improve that relationship going forward. But I'd be happy to answer any questions on that or wait to the end. I'd like to shift a bit to the industry restart and the relationship with CDC, if that's okay.
Why don't we let you finish and then we can
Great, thanks, Jim. You know, to date, and if I could just take from where Mr. Fain left off, you know, at the industry level for all the cruise lines operating under the conditional sale order since late June through today, you know, we're proud to report that more than 2 million passengers have sailed on more than 100 cruise ships out of U.S. ports since late June of 2021, and that throughout the duration of 2021, the level of passengers being COVID positive is well under 1%, even under half of 1% of all those that have sailed. And it's important to remember that it's not a zero risk environment. There will be COVID on board, but that where there has been COVID cases, that there are comprehensive measures in place to swiftly isolate, quarantine close contacts that are identified, and to keep those numbers low. And so in the context of the overall number of people who have sailed, which we want to, of course, see continue to go up in the months and years ahead, the numbers of COVID positive have been quite low. That's certainly attributable to the crew vaccinations, which are at 100% using approved vaccines, and crew are being boosted as soon as they're eligible. Passenger vaccinations are typically upward of 95%, and boosters are highly encouraged. And as Mr. Fain mentioned with testing, we have 100% testing in place. Every passenger is tested pre-embarkation, no greater than 48 hours prior to boarding, but in some cases, at the 72-hour mark, and then again at on the day of embarkation. And then thereafter on board, they have the capability to test diagnostically should somebody present with symptoms, and of course the very frequent crew testing regimen that's in place for surveillance. You know, it's pretty astounding. Just for the month of December, the cruise industry administered more than 1.2 million tests. That's 21 times the rate of testing in the United States. So, you know, when we say that we've detected cases on board, we should think that we would, given that comprehensive level of testing in place. So that's important to keep in mind against the backdrop of our restart. The protocols that have been put in place are really unrivaled by any other sector. You know, from communications across the full spectrum of the cruise experience, from the time of booking till disembarkation. You know, protocols that incorporate masking, vaccinations, enhanced ventilation strategies, medical facilities that were enhanced, sanitation and other science-backed measures informed, like the Healthy Sail Panel and other industry consultants that were engaged throughout the whole process, especially while the industry was not operating in the US. And those protocols have been pressure tested through the Delta surge, as well as the elevated case levels we're seeing with Omicron. But they're agile and they can be adapted quickly by the industry, often in advance of anything that CDC has been able to assess and respond to. It was during Delta that the industry implemented testing strategies and strategies for onboard protocols that preceded the similar measures put in place by the CDC. But all that just to reinforce that a theme presented earlier, that cruise ships do provide for a highly controlled environment, and one in which rapid response procedures can be implemented to maximize onboard mitigation and limit the onboard transmission. But we do have comprehensive reporting, daily enhanced data collection to the CDC. That is via portal-based system. It is quite labor intensive. It's burdensome, but there is a significant amount of data going to the CDC, and that's been, I think, the basis on which they have been able to assess the levels of risk presented. But we're pleased that, through the course of the CSO and the demonstrated performance of cruise lines implementing policies and procedures, that we are in a position where that's built confidence in the industry's ability to do so, which helps justify a transition to the voluntary program. So I would like to talk a bit about the transition to the voluntary program and the relationship with CDC there. And the voluntary program, based on the expiration of the CDC conditional sail order, has started as of the 15th, this past weekend. We do have some general knowledge of what the voluntary program requirements will be, which we received through a communication from the CDC. We don't know all the details of what it'll entail. We are in a bit of a status quo period right now, where the CSO has expired, but the industry has not been yet provided a date by which cruise lines need to affirmatively say we opt into this program. Though, as you can imagine, the protocols in place are at least or even more than what the CDC has required to date, so that the voluntary program should present itself as something that the industry would easily be able to comply with. But we are still awaiting some of the specifics on that. And we think that is quite imminent. We look forward to receiving that. I think then cruise lines will look forward to making their official declarations of opting in. As we go into the voluntary program, some key challenges I think that remain. First and foremost would be communication. As Mr. Fain said, we need to continue this regular dialogue that we've had with the CDC and the interagency in the United States, which has been very robust since April of 2021. We had a long drought where communications were mostly just an exchange of letters and with a strong desire to try to figure out where the mutual interests were. But since April of 2021, the dialogue has been robust, and that needs to continue even through a voluntary program to ensure that as we look forward and hopefully move from a pandemic situation to an endemic situation, that the requirements of a voluntary program are really fit for purpose and evaluated constantly so that they can be improved, receded if and when appropriate. And that dialogue allows for continual opportunities to get clarity on what CDC expectations are. And, there is, throughout the pandemic, there's been numerous instances where we would look at the requirements put in place for cruise lines, and they'd be disparate in many respects from other sectors of travel and tourism or from the general population. And we need to have that, I think, a very vigilant eye towards removing any of that disparity so that we can be on a level playing field with the rest of the American society and really move away from a situation where cruise as an industry is singled out differently, despite being in many respects a shining example of implementation of CDC guidance. So those are some of the challenges, as well as reconciling a transition to a voluntary program, the success of the cruise line protocols, while also having in place a level 4 travel advisory, which we, of course, disagree with the assessment, but understand that this is something that is based on what CDC evaluates for other countries. But to highlight the disparity and the singling out of cruise, when the level 4 travel advisory for cruise was put in place, remember, we're the only industry sector that has such a travel advisory. And also, it's the only travel advisory that came with the caveat of being independent of the vaccination status of the people on board. So if you look at the travel advisory for going to Chad in Africa, it's a level 4 travel advisory, but if you go, you should be vaccinated. Cruise, despite being under a CDC program, level 4 travel advisory in place, regardless of vaccination status. So reconciling of that could use some attention, and we are hopeful that that will transition back in the near future. But that is to say that at the very least, we have this robust dialogue with CDC that needs to continue. Meaningful engagement is both appreciated and necessary, and we look forward to being able to shift towards more risk-based guidance for the industry with the flexibility for the industry to implement that in ways that are best suited for the population on the ship or the ship type, which is historically the way that we've been able to do so. So Chairman, I'd like to thank you for your time. I'm happy to take your questions, and I realize you are also time constrained. So how can I be at your service?
Questions, folks? Let me, Richard talked about the issue of having to interact with multiple layers at CDC. Can you comment on that from your perspective?
Well, I think I would divide it into two timeframes. Shortly after the pandemic hit, and cruise operations were suspended in the United States in March of 2020. We had a good year or so where our communications were really just letter exchanges to the director and to some of the other senior leadership within the maritime unit that was responsive. And versus when we, on or about March, April of 2021, about a year or so later, as we were gearing up and had some a little bit more mutual alignment on what the CSO would be and getting restarted in the summer of 2021, we began a dialogue with the maritime unit, with whom we have a lot of experience talking, but had a good gap in our communication cycle, and interagency contacts from Department of Homeland Security, Department of Transportation, Department of Commerce, which provided a really good, well-rounded interagency approach to some of the challenges that, as a whole of government, the United States was facing with COVID policy. Kind of integrated with the very specific guidance that was needed for the maritime sector and cruise specifically that the CDC Maritime Unit was providing. So April of 21 onward, that interagency and CDC dialogue has been instrumental in getting us to where we are today and where we continue to need to go.
So what I think I heard was early on a focal response, mostly through email, and later on a more coordinated response integrated with a more whole of government response.
That's correct.
Okay. Jason and then Stephen. And I think that's the two questions we'll be able to take. Jason.
Yes. So the cruise ships could dock in different ports, and if there are if infections detected, and what's the current process? For example, if you're trying to dock into a port in the United States, and there are infectious individuals on board, how do you currently negotiate whether your ship could dock or not? And when passengers could disembark, what do you need to test everybody before people get out, or do they need to be quarantined? What's the current process?
Well, the current process is that even before you sail, you have prearranged understandings with those ports at which you call. That's part of the requirements under the conditional sail order. They'll be carried forward into the voluntary program so that you have an element of port agreements. Now, what's the real crux of a port agreement that I think everyone realizes is the same kind of coordination that any ship has for the port to which it sails. You want to make sure that you have the logistics in place. You want to make sure that you have readiness for any contingency and preparedness needs. So in this case, it has involved making sure that you knew where you'd house individuals if you had to ship them to shoreside quarantine, having relationships with medical facilities so that in the event you have to transfer somebody because they need critical care, that you could do so. I think in large part due to vaccines, boosters, and the comprehensive protocols in place, medevacs and hospitalizations for COVID have been extraordinarily low for cruise lines since the restart. So not having to rely on those too significantly means that the industry isn't a burden to the shoreside health resources, which is very important and was clearly one of the CDC's objectives as we moved towards restart. So we're glad we've been able to perform and demonstrate that we do so.
Thank you. Stephen.
Yeah, so this is just a really quick question, but you alluded to it as well as Richard alluded to it, that you represent 90% of the industry. You have to deal with lots of different regulatory authorities around the world, and that you were more successful with some than others. Do you have a particular model internationally that worked well from your perspective?
Thanks for the question. I think, the first area in which we got back underway doing revenue cruises was in Europe. That was in large part due to a dialogue that started very early with the EU Healthy Gateways, which is basically a health collaborative operated out of a university on behalf of many of the European countries. So that dialogue had a very early on, and this is like July, August, September of 2020, that early, where cruise ships started to sail on a limited basis, still with a phased-in approach. But the dialogue with those authorities started very early. There was a mutual commitment to public health, and we're able to find ways to get sailing started much quicker than we were here in the United States. So I think it did provide a good model, even across multiple jurisdictions where those first sailings started.
Also, again, I want to thank you very much for that. That was quite informative.